Assalamu alaikum wa rahmatullahi wa barakatuh. Welcome to the channel of Stand Medical Notes. So, in the previous video, we have learned about the normal chest X-ray and the silhouette sign. From now onwards, from this video, we will learn the pathological things in the chest X-ray. So, let's begin with the name of Almighty. So, first of all, we will discuss about the pathology of the parenchyma of the lung fields. Okay. So, in the pathology of the lung parenchyma, it can be of these types. Number one, alveolar opacification. Alveolar opacification, or also known as consolidation. Consolidation. Number two, collapse. Collapse. Number three, interstitial opacification. Number four, nodular opacification. Number five, increased lucency. Increased lucency, or also known as hypertranslucency. Translucency of the lung fields, nothing but increased blackishness. So these are the 5 kinds of pathological things which we can see in pathology of the parenchyma of the lung fields. So let's begin and let's see one by one of them. So first one, we will discuss about the alveolar opacification, nothing but consolidation of the lung. Okay, what is the pathophysiology here? Alveoli is normally filled with air, but in consolidation, instead of air, the alveoli are filled with either pus, for example in pneumonia, or water, for example in edema, or blood, for example in hemorrhage, or cells, for example in cancer. So either pus, water, blood, or cells. So replacement of the air with other material like pus, water, blood, or cells causes consolidation of the lungs. What is consolidation? So normally these are the grape-like alveoli, and these are connected to the bronchioles. Okay, bronchi and bronchioles. So these are filled with air and they are collapsible, they are stretchable like a balloon. Okay, but when they are filled with something other than air, they lose their balloon-like. They lose the balloon-like elasticity. Okay, and they become a somewhat, we can say, somewhat solid compared to the previous lung parenchyma, somewhat solid like structure. So because of that, many things we examine in, many things we will get as a clue during auscultation of the lungs also, and also in chest x-rays because of that. Okay, because the medium is changed now, the medium is not air. Okay, when the medium is changed, so the physiological laws will change there. Okay, so that's consolidation. Okay, so that is the pathology. The air is replaced by other things. Now what is the second thing? What will be the key radiological signs in consolidation? So air bronchograms, if present, then they are the hallmark of consolidation. Air bronchograms are nothing but, normally the alveoli are filled with air, but they are now not filled with air, they are filled with some pus or water or something like that. But the bronchi which are running in them, the bronchi and bronchioles, so they will have air. These will have air. These will have air, and apart this, so this part of alveoli which is consolidified, we will see as white patches in chest x-ray. Okay, so this part of the lung, so these bronchioles and bronchi which are filled with air, if they are present, then they can be seen as blackish, black dot like thing, like this, black dot like things. So these are known as, in between this, in these white patches, you can see this, you can appreciate these things. So these are known as air bronchograms, and if present, then they are hallmark of consolidation. Okay, then second, ill-defined fluffy or patchy opacities, nothing but whitishness. Fluffy means cotton like, or patchy opacities. But remember, there is no significant volume loss of the lung. So volume of the lung is intact. That's why there is no mediastinal shift or tracheal shift in consolidation. Remember, there is no tracheal shift or mediastinal shift in consolidation because the volume is intact. Volume of the lung is intact. So depending upon the distribution, we classify this consolidation. Okay. So if it is confined to a lobe, then it is lobar consolidation, and it is commonly seen in Streptococcus pneumoniae infection. Streptococcus pneumoniae. If it is multifocal, means not a single lobe, it is not involving a single lobe, but uh, a patchy involvement of different lobes is there. So then that is known as bronchopneumonia, and that patchy segmental opacities you can see in the X-ray of these patients. These are also pneumonia patient, and this is classically caused by Staph aureus patients. Staph aureus patients, and also viral pneumonia presents as bronchopneumonia, multifocal patches. Remember this point. Viral pneumonia also presents as bronchopneumonia, multifocal pneumonia. Okay, this is the two types of consolidation, infective consolidation. Okay, so here the alveoli are filled with infected fluid, or you can say if they progress or pus. Okay, now the next thing is batwing or butterfly appearance. We will see what is that. So what is batwing appearance or butterfly appearance? There is bilateral perihilar consolidation. So you have the hyla of the lungs, here one and here hyla. These are the hyla of the lungs, and these are the lungs. Okay, so consolidation is mainly concentrated around the hyla here. The consolidation is mainly concentrated here. That's why this is known as bat wing like appearance of the lungs. So here will be the bat, something like that, and these are its wings around the hyla. So this type of bilateral hilar consolidation you see in cardiogenic pulmonary edema. So pulmonary edema due to cardiac cause, cardiogenic pulmonary edema. Or one more thing, reverse batwing appearance. So this is opposite to this. Here you see batwing perihilar, what do you call, opacities, consolidation. But in reverse batwing, so you have consolidation in the periphery here. So this is reversed batwing. This is reversed batwing. Periphery, you have the, in the center you will not have any consolidation, but in the peripheries of the lungs you will have the consolidation. So that you see in chronic eosinophilic pneumonia, which is rare type of pneumonia which is found in parasitic infestations, like, or some million parasitic infestations. Okay, so reverse wing appearance we call it as. Okay, so these are the types of consolidation which we see in a chest X-ray. So what is that? So one is lobar pneumonia, one is multifocal or bronchopneumonia, and the batwing appearance and reversed batwing appearance. Okay, now we'll move forwards. So see at this X-ray. Okay, this image. Okay, so alveolar opacification or consolidation or airway opacification seen on chest X-ray means something other than air which fills the alveoli. So what is the characteristic features we see? Ill-defined patchy coalescent areas of opacification, no loss of volume, air bronchogram. What are air bronchogram? The air-filled bronchi are outlined by the opacified whitish gray alveoli. If the bronchi contain fluid, there is no air. That's why I said it is not necessary that every consolidation does have air bronchogram, but if they are present, then that is a hallmark of consolidation. Extension to a fissure. This is important point. Remember, consolidation will not cross the fissure, oblique fissure or the horizontal fissure. Consolidation confined to a lung will not cross the fissure. So that is also an important point of consolidation. So we have learned that it can be lobar consolidation or multifocal or batwing or reverse batwing. Okay, so these are the pictures which depict that thing. Sorry. Okay, so here you can see, I will just do this thing. See here, this is consolidated lung. Okay, this is these things, whitish thing, consolidated alveoli, and in between, in them are the running bronchi, bronchioles, everything which are filled with air. So these are seen as air bronchograms, and this is seen as patchy white opacities, and this is the heart. Okay, so that is a good depiction. So see here now, this is one example one. So you can see here there is a patchy wedge like opacity which is present in the middle zone of the lung. This is at the middle zone of the lung, and also silhouette sign is present here. You can see silhouette sign, cardiac silhouette sign is present. And remember, we know that the left border of the heart is touches the lingular part of the upper lobe of the left lung. So that means it is lingular pneumonia. So pneumonia or consolidation of the lingular lobe of the left lung. Okay, let us see whether it is right or wrong. See, I said no. So A is nothing but lingula. Okay. Now coming to the second lobe. Now you can see here there is opacification here also. These are the fluffy or cotton like opacities, but the cardiac border you are able to differentiate. That means it is not involving the middle lobe and it is in the lower zone. That means it is lower lobe pneumonia, right lower lobe pneumonia. Okay, so we'll see this whether we are right or not. Okay, see, yes, it is right lower lobe pneumonia. Okay, now we'll see the third. Okay, you can say no. So it is involving the upper zone of the lung, right upper lobe of the lung. Okay, and also you can see some tracheal shift to the right side here. Okay, I think along with consolidation some collapse is there here maybe, but definitely there is consolidation which is confined to the upper zone. So this is upper lobe pneumonia, right upper lobe consolidation, right upper lobe pneumonia. Okay, for example, air bronchograms. No, see here. I will say what are the air bronchograms. So this is the whole white opacification. In this, you are able to see these minute blackish things. Okay, these minute blackish things, or this like blackishness. Okay, so these are nothing but the air bronchograms. Air bronchograms, and these are hallmark of pneumonia. Okay. Okay. So we have learnt about this one. So pneumonia is one of the major death causes related to infection. The most common bacterial pathogen include Streptococcus pneumoniae, which causes lower consolidation staph, causes multifocal pneumonia, Klebsiella pneumonia, and H. influenzae. Viral pathogens include COVID-19, varicella, and remember, viral pneumonia is also bronchopneumonia. Fungal pneumonia, pneumocystis pneumonia is virtually never seen in immunocompromised. It is seen in immunocompromised like HIV patients. Okay, fungal pneumonia. Lobar consolidation is the most common consolidation type. Lobar consolidation is the most common consolidation type. We will see the next X-rays, picture of next X-rays. Okay, so these are one more picture we are able to see here. Okay, so if you divide this, now first see the trachea. Yes, it is equidistant. Trachea is equidistant, or I think it is slightly rotated. Yes, the patient is rotated slightly. The patient is rotated slightly to the right side. If I draw a midline, this part is greater than this part. This is greater than this lesser part. I think the patient is rotated to the right side, but exposure is okay. Exposure is okay. And if you count the ribs, number of ribs, then 1, 2, okay, 3, 4, 5, 6. Okay, then inspiration is also good. But if you divide it into zones, for example, this is the upper zone, this is the middle zone, and this is the lower zone. Okay, so you are seeing opacification here also and here also. So, and you can appreciate the border of the heart also. That means silhouette sign is absent. But at this point, somewhat okay, you can appreciate. So I think it is involving the lingular part along with some parts of the upper lobe of the left lung. Lingular plus some upper parts of the lung, upper lobe of the left lung. And these are nothing but the air bronchograms. See, these are all air bronchograms. Which are the hallmark of consolidation. Let us see what is this. Lobar consolidation involving the left upper lobe, mainly the lingula. See, I said no. So it is involving the left upper lobe, mainly the lingula. That's why at this point, you are not able to appreciate the heart border. But at this point, you are able to appreciate. Okay, that's why I said there is involvement of lingula and part of the upper lobe. And air bronchograms we are able to see. I showed you. Now this is a lateral chest X-ray of the same patient. Okay, and this is the horizontal fissure, and this is the oblique fissure, and this is the horizontal fissure. Now see, this is the consolidation, and it is not crossing the fissure line. So that is the feature of consolidation. It will not cross the fissure line. Okay, so we have seen this image also. Oh, sorry. Now I'll move forwards. That was lobar pattern. Now we will see multifocal distribution or bronchopneumonia. Okay. So pneumonia is the most common cause of lobar and multifocal consolidation. Lobar consolidation is also seen in patients with lung contusion and infarction, certain carcinoma, as well as in some inflammatory conditions. Besides bronchopneumonia, multifocal consolidation can also be manifestation of neoplasms and septic emboli. The clinical history is essential for the differential diagnosis, in particular distinction between acute and chronic consolidation. The most common causes of acute consolidation are pulmonary edema, so batwing appearance, no, acute consolidation are pulmonary edema due to heart failure, cardiogenic pulmonary edema, pneumonia, and aspiration. Remember this point. The most common cause of acute consolidation are three things: pulmonary edema, cardiogenic, and pneumonia and aspiration. Whereas neoplasms, sarcoidosis are common causes of chronic consolidation. Neoplasms, inflammatory and malignancy. So infective, pulmonary edema, and aspiration. These three are common causes of acute consolidation, whereas inflammatory and malignancy are common cause of chronic consolidation. Okay. Now you can see here this image. Okay. So exposure is okay, trachea is okay. Okay. And you are seeing multiple signs of consolidation. See here, this is lingular lobe, and here also some patchy opacification. Here also opacification. If you divide this into three zones, okay. Here also you are seeing opacification. Okay, patchy, multiple. Here you can see air bronchograms. See, these are all air bronchograms, and uh, so mainly you are seeing increased whiteness in bilateral side, increased whiteness in bilateral lungs. So multiple lobes are involved. Multiple lobes are involved. This lower lobe, this is lower lobe, this is lingular lobe, okay, and this is the upper lobe of the lung. So multiple lobe is involved, and if you take the lateral chest X-ray, this is the oblique fissure, and this is the horizontal fissure. Not able to make out. This is the oblique fissure. So this is the middle lobe of the lung, okay, and this is the upper lobe opacification, and this is the lower lobe, left lower lobe, sorry, right lower lobe opacification. So multi lobar involvement you can see here. So let us see what is this. So multi alveolar opacification in bronchopneumonia, that is nothing but Staph aureus, involvement of both lower lobes. Yes, here we are able to see involvement of both lower lobes. Middle lobe, blue asterisk, this is the middle lobe, okay, and alveolar, lingular lobe actually, and upper lobes including the lingula. Here upper lobe is involved, lower lobe, upper lobe, and lingular lobe. Sharp delineation of the horizontal fissure, torquis arrow, but I can appreciate only this oblique fissure, okay. In CT scan, I think he's saying, see, this is the CT scan of these lungs. This is the horizontal fissure. So this is the arrow. So there is a sharp delineation with the horizontal fissure. So it is a multifocal involvement overall. Just to remember, it is a multifocal involvement. So mainly it can be viral or Staph aureus pneumonia. Okay. Now that was the one example to show multi-lobar involvement. Okay. Now we'll see Batwing and reverse Batwing distribution, which is seen in accumulation of fluid in the lungs. Okay, see this X-ray. You are seeing concentrated opacification around the hyla of the lungs. Okay, so this is known as the, see this picture, butterfly or batwing appearance of the lungs. So this is cardiogenic pulmonary edema. You are seeing bilaterally. Okay, cardiogenic pulmonary edema. This is an example of cardiogenic pulmonary edema. And in this lungs, this is just opposite to the this X-ray. So here you are not seeing perihilar, but here you are seeing at the peripheries of the lung. Bilateral you are seeing. Peripheries are also. It is an example for eosinophilic pneumonia. It is rare, but just remember. Okay. Eosinophilic pneumonia. Okay. So that is the, these are the X-rays. These are the types of consolidation which we usually see. So bilateral perihilar alveolar opacities. This pattern is seen in frontal chest X-ray and on CT. Most common cause is cardiogenic lung edema. Okay. Reverse Batwing opacity is bilateral peripheral alveolar opacity, sparing the perihilar regions. The most common cause is chronic eosinophilic pneumonia. Okay, now we'll move forwards. So that was the one type of pathology which we see in uh, lung in chest X-ray. That was consolidation we have discussed now. Okay, lobar consolidation or multifocal consolidation or bronchopneumonia and Batwing appearance and reverse Batwing appearance. Now we will see the second number of pathology, that is atelectasis or collapse. And remember, in this you will have the volume loss of the lungs. This is important. When there is volume loss, there will be tracheal and mediastinal shift. Okay, there is tracheal and mediastinal shift. So you have volume loss of the lungs. So collapse is nothing but, just remember, if you imagine lung as a balloon, so it is a deflated balloon. So deflated balloon. Uh, so so just imagine a deflated balloon which has lost its volume. So when it is filled with air, it will have some volume, but whole air is out from a part segmental or subsegmental from the lung. So that part of the lung will get collapsed like a deflated balloon. So that is nothing but atelectasis. Okay. So what is the pathology? Lung has lost volume, opposite of consolidation. Okay. So there are four types of collapse, four mechanisms. It can be obstructive, it can be compressive, it can be relaxation, or it can be due to contraction. Obstructive is because of airway blockage by tumor cells or some mucus plug, for example, in asthma patients or COPD patients. So or pneumonia patients also. So distal air is absorbed now. So for example, this is the bronchi which is going to a bunch of grace, meaning a lobe. Now this part is blocked. So the air here is absorbed and this will get deflated like this. Okay, this border of that will come to here. So that is the mechanism that will cause collapse. Compressive is some external mass like tumor, a large tumor is pushing on the lung. So that is forcing the lung to get collapsed. That is compressive collapse. Relaxation. Lung separates from chest wall. Oh, for example, pleural effusion or pneumothorax. So when the pleural cavity is filled with water, or sorry, pleural large amount of pleural fluid, or when it is filled with air, so what will happen? That air or that fluid will cause passive collapse. Passive collapse, how? It will not allow the lung to uh, relax fully. So that will cause passive collapse of the lung. Remember how you will imagine that. So if it is an inflated balloon, okay, if it is an inflated balloon, so but it is kept in a tank which has water. So what that water will do? It will compress this lung. So that will cause something like that, but that is not totally deflated. Okay, this type of collapse is known as due to relaxation. So that is in pleural effusion and pneumothorax. Okay. So the last one is contraction due to, so some fibrosis or scarring pulls the lung tissue, which will shrink it. So if this is a lobe of the lung, so some scar will pull this lung tissue downside, so causing it to collapse. So that is the fourth type. So due to obstruction, okay, or due to compression, so this is common obstruction, and this relaxation is also common, and contraction, this is also common. Compression is there, carcinoma, depending upon the, so carcinoma is not seen in every patient. No, so this obstructive and relaxation and contraction you see most commonly, sorry. So what are the key radiological signs then? So the key radiological signs are nothing but the signs of volume loss. What are the signs of volume loss? The mediastinal shift will be there towards the side of collapse, and this is the most important sign of collapse. So mediastinal will shift towards the type of collapse. There will be fissure displacement. Remember, in consolidation is confined to the fissure, whereas the fissure is displaced towards the collapse. So mediastinum is also displaced towards the collapse. Fissure is also pulled towards the collapse. Ipsilateral diaphragm elevation. So that nothing but the collapsed lung is pulling everything towards itself. So it is pulling mediastinum, it is pulling fissure, it is pulling diaphragm. That's why the diaphragm is tented in case of the dome shape will take a shape of a tented. I will show the fissures, and there will be crowding of the ipsilateral lips. Why there will be crowding? So the space between the crowding is nothing but you will lose the space, normal space which is present in between the ribs. So when the space is reduced, so there will be crowding, the ribs will come to closer. This is nothing but crowding. Why they come closer? Because here the volume is lost. So when the volume is lost, so ribs will come closer. So these are the four important signs of collapse: mediastinal shift, fissure displacement, diaphragm, and crowding of ipsilateral lips. And one more thing is uh, compensatory hyperinflation. So how you identify hyperinflation in collapse? The space between the ribs will be increased, that is hyper. It is opposite to crowding. It is opposite to crowding. So the space between the ribs will be increased, that is compensatory hyperinflation of the other part of the lung if the collapse is involving only a part of the lung, or if whole lung is involved, then there is a compensatory hyperinflation of the other lung. Okay, so there is compensatory hyperinflation. Okay, so these are the signs, important signs of collapse. So these are the examples. So these are the pictures which are showing the same mechanism. So when there is mucus plug, this is the lung which is getting deflated. So here it is in the, sorry, not whole lung here, because it is involving the upper lobe. So upper lobe is getting collapsed here. And here some compression by a tumor which is causing collapse. And see here effusion or some air which is causing passive collapse of the lungs. And here contraction. Why contraction? So some scarring or something that will not allow the lung to inflate, to relax, and it will pull the lungs. So that by that there will be collapse of the a part or whole of the lung. Okay, so these are the mechanisms we have seen. Now we'll see the chest X-ray. Okay. So remember, collapse can be subsegmental involving a part of lung segment, or it can be segmental involving a lung segment, or it can be lobar involving the entire lobe, or it can be complete lung collapse. So if this is a lung, okay, and this is a lobe of the lung, and this is a segment of the lung, and this is a subsegment of the lung, so collapse can be subsegmental, okay, or it can be segmental, or it can be lobar, or it can be complete lung collapse. But one thing you need to remember is important feature. Collapse of each individual lobe is associated with typical imaging features. To see the typical features of collapse, at least one lobe of the lung should be involved. So there should be a lobar collapse. So you can appreciate the features of collapse properly when there is a lobar collapse. Okay. Okay. Same thing is explained here. Okay. Same thing is explained here. So now we will see the X-rays. See this X-rays. So first we'll see this. So see here, this is the trachea and the clavicles are equidistant, and these are just visible. Okay, rotation, and ribs are also okay, 5 to 6 ribs. Okay, now just to see here, you can appreciate a border like opacification. This is opacified area, and you can appreciate a border here. Okay, and see, I said no, here the diaphragm is tented. I will show like this. This border, tented border, you can see. Okay, tented border, and this is the upper lobe. Remember, this is the upper lobe. And one more thing I will show you. You can see this is the mediastinum, and you are seeing more vertebrae behind the vertebrae which are present behind the heart, thoracic vertebrae. You are now able to appreciate the discs also. That means the mediastinum is shifted towards the left side. Yes, the mediastinum is shifted towards the left side, and there is tenting of the diaphragm. Okay, and here you can appreciate the clear border, lung border. So it is upper lobar collapse, and see the tracheal displacement is also there. White blackish air you can see now. So this trachea is displaced to this side, and also you can see. So you should see crowding of ribs. Okay, you should see crowding of nothing but you should the space compared to this space. Okay, yes. So if you see this point of the lung, see here the space is much more than the space in these between ribs, in these ribs. So intercostal spaces in this chest X-ray these are reduced space, and these are increased space. That means this is compensatory hyperinflation. Similarly, you can see here, see the space between the ribs is increased here also. So here also the opposite lung is compensatory hyperinflated. So what and all you have seen, all the signs of collapse you have seen. This is a case of upper lung collapse. Okay, and in a lateral view, see in a lateral view also what you are able to appreciate here, you're not able to appreciate a important where is that oblique fissure. You're not able to appreciate the oblique fissure. The oblique fissure is gone here. Okay, that is retracted actually towards the upper lobe. So let us see. So the same X-ray is explained here. Sorry. You can see here, this pink one is, no, this is the mediastinal shift, and this is the tracheal shift, and this is the upper lobar collapse, and this is the border of the lung. Okay, and this is the crowd, this is hyperinflation. Okay, this is hyperinflation, and this is also compensatory hyperinflation, and this is stenting of diaphragm. So I was not able to appreciate the oblique fissure, but they have shown here it. See, this is the oblique fissure. This is the oblique fissure here. Okay, so the collapse will pull the fissure also. Left upper lobe atelectasis, characteristic upwards displacement of the interlobe fissure while remaining attached at the hilum. So here the fissure is displaced upside. Here also you can see this is the upper lobe collapse in the lateral side. See, this is the displacement of the interlobar fissure. Okay, so that's about left upper lobar collapse. Now we'll see this X-ray. Okay, first we'll see, then we'll analyze whether we were right or wrong. You can see here, okay, this is the trachea. Okay, this is the trachea. Okay, if you divide the lungs again, 1 2 3, okay, you can see slight tenting of this diaphragm, and this is the opacification. Okay, this is the opacification. You can see the border also. See, border also. So this is middle lobe. You are able to appreciate the silhouette sign also here. Silhouette sign is present. That means it is middle lobe. Okay, middle lobe, and see the ribs are hyperinflated. See the intercostal space. So compensatory hyperinflation is also there. Here tenting is also there, and the interlobar fissure here, it is I think it is stretched down. It is pulled downwards here, and this is a right middle lobe collapse, I think. Okay, and you can see here the mediastinum is shifted towards the right. You can appreciate this pulling. Okay, the trachea is shifted towards the right side. Same thing. See, the oblique fissure is here, but the horizontal fissure is pulled downside. Okay, let us analyze our findings, whether we were right or wrong. See here, classical signs of right middle lobe atelectasis. Yes, we were right that it is my middle lobe because silhouette sign was there. As seen in chest X-ray, include homogeneous pulmonary opacification. Yes, orange star. Displacement of interlobar fissures towards the atelectasis. So this is the oblique fissure. This is the horizontal fissure which is displaced towards the collapse. Okay, and upward displacement of the oblique fissure. Okay, this is the oblique fissure which is displaced upward. Oblique fissure which is blue line. Yes, displacement of right hilum towards atelectasis. Closeness of the ipsilateral lips, yellow lines. So these lips are closer. That means there is crowding. Okay, so we were right that it is right middle lobe collapse, but not consolidation. You are not able to appreciate the mediastinal shift that much, but this is the right hila. Of course, this is the right hila which is coming to the right, towards the right side of the lung more. But this tenting is the characteristic thing which will give us a clue that it is not consolidation, it is a collapse. Okay, okay, so the last picture we will see here, okay, of collapse, and then we will end the topic. So first we will see this one. So okay, first we'll see here now if you compare here, okay, see this is the trachea is shifted towards the right side of the lung, and there is whole lung is whitened out here. Whole lung is whitened, and the heart is also pulled towards the right side. Then so this is how you will say that it is a collapse or consolidation. So the trachea is pulled towards the whitened part. That means it is total lung collapse of right lung, total lung collapse of the right lung. And you can see increased whiteness of the left lung also, increased whiteness of the left lung. That means there is compensatory hyperinflation of the left lung. Okay, similar things you can note here. Okay, so this is increased opacification. Okay, so we have made out that it is a right. Just if you make out that it is a right total lung collapse, then it is enough. Sorry. Okay, so right lung collapse caused by right main bronchus obstruction due to lung cancer. Oh, it is a patient of lung cancer. Homogeneous opacification, orange stars of the right lung. Displacement of the mediastinum, pink arrows towards the right. So yes, there is displacement of deviation of the trachea. Closeness of the ipsilateral lips. We are not able to make out ribs only. Okay, and compensatory hyperinflation we are able to make out of the left lung. Okay, and oligemia. Oligemia is nothing but decreased blood supply to the vessels in the vessels of the lung. That is oligemia. Herniation across the midline, retrocardiac opacity on the lateral chest X-ray corresponds to the collapsed lung. Retrocardiac opacity is nothing but the opacity which is present behind the heart, this part. So this is the heart. So that is nothing but the right lung collapse. So it is right lung collapse. Similarly, this is left lung collapse. Yes. So this is left lung collapse. Same things. Okay. Whole of the lung is collapsed. And this is after treatment. See, this is after treatment. This is after treatment. Okay, whole lung is collapsed. There is mediastinal tracheal shift also there, mediastinal shift also there. There is compensatory hyperinflation of the opposite lung. So everything point out towards the collapse. So here near total left lung collapse caused by left main bronchus obstruction due to a mucus plug in a patient with cystic fibrosis. Homogeneous opacification of most of the left lung, displacement of the mediastinum to the left, trachea displacement to the left, closeness of ipsilateral lips, and compensatory hyperinflation of the right lung, radiolucency, and herniation across the midline. Chest X-ray obtained the same day after endoscopic removal of the mucus plug shows collapse disappearance. I said no, that was treated. The second X-ray, this one. So this is a treated part. Okay. So that's all about the collapse and consolidation. This is enough for now. We'll meet in the next video. Thank you.